excited to go through some of the data with you. I'll tell you from the get-go that we are going to really skim through some of the data. We've already gone through all of it in the sessions today, and we're really going to try and spend more time in our interaction with AI. We will introduce you to AI Jane, and also discussion of the topic as well. I'd like to introduce Dr. Julia Roto from the Dana-Farber Cancer Institute, Dr. Ann Chang from Yale. Thank you both so much for being a part of the discussion. Thank you to all of you for coming and attending, and to those of you online. We also want to thank PeerView for providing this session, and for AbbVie, AstraZeneca, and Daiichi Sankyo for providing the educational grants for the symposium. Please do complete the pre-event survey, and also you should have cards on your table with QR codes to pull out your cell phones and tee those up as we're going to go through some questions along the way. This is that QR code. It is on your table as well. I think I see it on all of them, so I'm gonna continue. As we go through, there will be post questions as well, and that you'll be answering with your cell phone as we continue the discussion, just to keep things moving along. Please do visit peerview.com/lungadc25. You can see the slides. So some of the slides we're really gonna skip through somewhat quickly, but you can go back and review those as well. So our goals for this are really to enhance your knowledge of efficacy and safety of ADCs, improving skills, and equipping you with strategies for optimal integration of ADCs. As I mentioned, we are going to interact with AI Jane. We'll be asking her questions. Not everything she says might be right. So we'll, she's not the one that's just going to give us all the answers. We'll actually see what she says, and then we'll discuss that as well. First, I'd like to turn it over, though, to Dr. Julia Roto for HER2.
Thanks, Dr. Sands, and great to be here today. So we'll start out talking about HER2 ADCs in non-small cell lung cancer. So first, a quick polling question for everyone to get us started. So do scan through the QR code. And our first question is, which HER2 test results are clinically actionable today? And you can choose HER2 non-tyrosine kinase domain mutations, HER2 kinase domain mutations, HER2 2+ status by IHC, and here I'll say in lung cancer, clinically actionable, HER2 amplification, at least fivefold on your NGS assay, answers 1 and 2, answers 2 and 3, all of the above, or you're not sure. Give everyone 1 second here, and then we're going to see the answers come up.
While you're answering that, I'll also just say, remind you that also you can submit questions as well, and so we can answer those as we go.
And this is great starting us off, because we're going to talk about this, and we have actually a lot of votes for I'm not sure, and we'll kind of go through, I think, our data, and then we'll return to what the answers are here, I think, in the post-test. So we're going to ask this question, some questions about HER2 testing to our AI here. So our first question to AI is going to be, when is the optimal time to test for HER2 expression status in non-small cell lung cancer?
HER2 testing in NSCLC should be performed at the time of initial diagnosis, along with testing for other molecular biomarkers. This is because 1. HER2 alterations, including overexpression, are associated with poor prognosis in NSCLC. 2. HER2 alterations are now recognized as an emerging biomarker of clinical value in lung cancer. 3. Early identification of HER2 status can guide treatment decisions, especially with the FDA approval of trastuzumab deruxtecan, or TDXD, for HER2 mutant NSCLC. HER2 testing is typically done as part of comprehensive molecular profiling, which is recommended for all patients with advanced NSCLC. It's important to note that there is currently no consensus on the definition of HER2 protein overexpression in lung cancer. If initial testing is negative or inconclusive, retesting may be considered at disease progression or when considering new treatment options.
All right. So we're going to run through a little data here, and then we're going to talk as a group and critique what we feel about that answer. So just quickly, what does it mean to be HER2 altered in lung cancer? Well, there's three definitions, three-way to test. HER2 mutation status, so activating mutations via, say, NGS. Overexpression detected by IHC, where right now the actionable biomarker is 3+ overexpression, or amplification, which is excess genomic copies, again, usually found in an NGS assay. So here in lung cancer, we're looking at activating mutations, kinase domain and non-kinase domain, so harking back to our question. Within the context of HER2 mutations, this has become a challenging space in some ways because there are many different activating mutations which can be encountered, most commonly being the exon 20 insertions. But unlike EGFR, activating mutations in HER2 are spread out throughout essentially all the multiple different domains of the protein, including outside the kinase domain. The NCCN right now recommends HER2 mutation testing as part of comprehensive genomic testing, typically done upfront at initial diagnosis. And they also do give guidance around HER2 IHC testing, here again looking for 3+ staining, typically done using a gastric staining criteria at this time, but it really doesn't give us clear guidance as to when the right time is to test. So I know we just asked this question to our AI, and Jacob, I don't know if you want to take us through a discussion on this.
Yeah, so, well, how do you think AI Jane did with that?
You know, I think she did pretty well. She recommended testing, which is fantastic. But I do think, as is often the case, frankly, for all of us as well, there was some confusion in the answer between molecular profiling, looking for activating mutations, and IHC profiling, looking for overexpression. And here I think the answer really focused on molecular profiling, which is fair, though I do agree that as part of comprehensive testing, it makes sense at initial diagnosis. She also touched on the idea of retesting potentially, or if you don't know the status later on therapy, which I think makes sense, partly because we don't know how HER2 expression status may evolve with time on therapy. So I think, I'd add that to her answer as well, perhaps. Yeah.
Okay, excellent. Can continue. We'll save some time for discussion of that.
Sounds good. So we have another polling question for the group, which is a 56-year-old woman with metastatic lung adenocarcinoma. She has a HER2 S310F mutation, so made this difficult, who was seen at disease progression following treatment with carboplatin, pemetrexed, and pembrolizumab. And what would you offer as next line of therapy? You could give afatinib, docetaxel, trastuzumab deruxtecan, trastuzumab emtansine, docetaxel pertuzumab, or you're not sure. And we'll give everyone one more chance to vote on this. Here, and again, a split vote between trastuzumab deruxtecan and I'm not sure, which is a fair answer for HER2 mutations, particularly non-exon 20 insertion mutations, where often my answer is I'm not sure as well when I look at the genomic report. And here I think certainly the ability to look online and have resources available like OncoKB and others can be very helpful to understand, is this actually actionable? And here the answer is it is actionable. It's a pathogenic mutation and is reasonable to treat around it. So what is the data for treating HER2 mutated, HER2 expressing lung cancer right now? So we'll talk first about the Destiny Lung 01 study, which is a multi-cohort study evaluating HER2 mutated disease as well as HER2 overexpressing disease. We'll talk about HER2 mutated first. This is the response data. This is why we're using this agent in clinical practice, showing response rate of 55%, again, across almost exclusively here in the study, kinase domain mutations, although a few of those light bars are extracellular domains. There's a few mixed in, including at least one with response to therapy. This PFS OS, certainly at PFS 8.2 months in this trial is, I think, clinically meaningful. Now, toxicity is something we see with ADCs. TDXT is likely familiar to many here if you're using this in clinical practice already. We do see some of these cytotoxic-based toxicities like nausea, fatigue, cytopenias, and very importantly, we do see ILD or pneumonitis on treatment. And that's something to be aware of and educating patients about when you design the drug for rapid identification and treatment. Because of the toxicity profile seen in the original dosing of Lung 01, which was 6.4 milligram dosing, our actual approved and dose that we're using in clinical practice is the 5.4 milligram dosing that's based on Destiny Lung 02, which showed that between these two dose levels, there was comparable efficacy, but less toxicity, less grade 3 AEs, and less drug-related ILD, which is why this is now the dose we use in clinical practice. So one question that often comes up for lung cancer is managing CNS metastases. Will ADCs be CNS active? They're large compounds. The answer is yes, they do appear to cross the blood-tumor barrier, and we see response rates in admittedly smaller CNS cohorts that are at least comparable to those of systemic response, as shown on the waterfall plots here, actually at both different dose levels. So what about HER2 overexpressing non-small cell lung cancer? This is returning to the original cohorts from Destiny Lung 01, now looking at those who are HER2 IHC 2+ or 3+ positive, and here also showing responses. Now for overexpression, the response rates are more modest, so 26 to 34% here, depending on the dosing cohort, so a little lower than the 55% that are seen in HER2 mutant lung cancer, but certainly clinically actionable. There was a follow-up study, Destiny Lung 03, which looked at this data now prospectively, specifically in patients with HER2 2+, 3+ overexpression, and again showing response rates here. If you break it down, higher response rates with higher HER2 overexpression. So you can see response rate here in IHC 3+ patients of 56% in this study. So before we continue, there is a follow-up polling question, which is, I think, a repeat of some of the earlier questions you did, hopefully right as we got started. So please take a moment while we continue forward, and we'll continue the discussion. And we're going to go back to AI and now ask our AI a few questions that have to do with clinical uncertainty about how to apply this data. So our next question for AI is, what's the best line of therapy, in which case to use HER2-targeted ADCs in HER2 overexpressing non-small cell lung cancer?
As of February 2025, the optimal line of therapy for using HER2 antibody-drug conjugates, or ADCs, in HER2 overexpressing NSCLC is not definitively established. However, current evidence suggests that HER2 ADCs, particularly TDXD, are most commonly used as second-line or later treatment options. TDXD has shown promising results in HER2 overexpressing NSCLC. While these results are encouraging, it's important to note that 1. The approval and most clinical evidence for TDXD are in the second-line or later setting, after patients have received prior systemic therapy. 2. The efficacy of HER2 ADCs in HER2 overexpressing NSCLC appears to be less pronounced compared to HER2 mutant NSCLC, where TDXD has shown higher response rates. 3. Current guidelines and approvals do not specifically recommend HER2 ADCs as first-line therapy for HER2 overexpressing NSCLC.
All right, so what do we know about line of therapy? And this is really difficult. If you look in the NCCN guidelines for HER2 mutations, it's very clear. They recommend second-line setting is something that we're using in standard therapy. But for HER2 overexpression, it's more reported as a therapy that be considered, but not really defined in line of treatment. What was done in the studies, these patients were pre-treated in Lung 03. So you can see here identifying baseline characteristics. About a third had prior chemotherapy, about a quarter had prior immunotherapy, half had prior targeted therapy because there were EGFR mutated patients on this study, and a subset had even had other single agent later line chemotherapy. So again, usually the second line or later, I agree with the AI on that comment. I think we're going to not go backwards. There we go. And here's what the NCN has to say. They simply say it's the sequence therapy. Again, I think leaving a little flexibility to us. So what about using this earlier in the frontline setting? Certainly there's a lot of interest. Can we target HER2 as we do other drivers first line? And there are a number of clinical trials ongoing. I've highlighted a few here, including the Destiny Lung 04 trial, which is TDXD versus chemoimmunotherapy frontline. And there are also HER2 TKI studies ongoing. So the BAY292 compound, as well as longertinib, also both being randomized versus chemoimmunotherapy. So hopefully we'll know more about optimal line of therapy. And I'll highlight these are all for HER2 mutant lung cancer, not for HER2 overexpressing.
So along those lines, now you've already said AI Jane fairly well. We can't really definitively say line. I kind of broadly said second line and beyond more broadly. So I'm going to ask you a couple. We have kind of a slew of questions online, so thank you for those submitting. Some of them were about what's now been answered. I'm going to combine two. So would you give TDXD to a patient with IHC2 FISH, confirmed HER2 overexpressing non-small cell lung cancer? And then follow up, another question was, is HER2 low relevant in non-small cell cancer like in breast cancer? And do patients respond to TDXD?
It's a great set of questions. I think there's been a lot of excitement around the data looking at lower expression of HER2 as a target in breast cancer. In lung cancer, we don't have that data available, and we really the patients who've enrolled, we've seen 2+, 3+ only. And we do see a dose response effect in that your higher your IHC score, the higher your outcome. So I don't know yet. I wouldn't use it clinically in a negative or IHC 1+. I also, FISH is an interesting question. Again, in the breast cancer literature, you might use it as a tiebreaker historically, but that's really getting to amplification and genomic changes, which right now has not been an actionable target in lung cancer. So right now I'm not using that in practice.
Separate cancer, Anne, as far as the toxicities then of TDXD, ILD was mentioned, low numbers, but need to be aware of. Any other toxicities that you think are worth highlighting?
I think it is important to remember that you can have heart failure or you can have effects on the heart, so that if you have a patient who's on therapy, drops to an EF of 40, you need to stop the drug. And it really hasn't been studied in patients with symptomatic heart failure. So just need to, pretty low percentage, less than 5%, but something to have in the back of your mind for your patients. We certainly have patients with comorbidities.
That's fair.
Great.
Go forward. All right, we're going to ask AI another challenging question, I think, that impacts us in the clinic. Think about HER2 mutations. Many of these are tyrosine kinase domain mutations, exon 20 insertion mutations. I'm going to ask AI, now focusing on HER2 mutations, should non-small cell lung cancer with a non-exon 20 insertion HER2 mutation receive HER2-directed therapy?
Non-exon 20 insertion HER2 mutations in NSCLC are less common and have shown different characteristics compared to exon 20 insertions. There is less clinical evidence supporting the use of HER2-targeted therapies in these patients compared to those with exon 20 insertions. While HER2-targeted therapies are not as well established for non-exon 20 insertion mutations, they may still be considered in certain cases.
So I'm going to show just one slide on this data, then we'll discuss. So, and here I will highlight that there is less evidence for non-exon 20 and non-tyrosine kinase domain insertions. You can see in here Destiny Lung 02, I just pulled an example waterfall plot. Each of these trials did have a smattering of non-kinase mutations enrolled, though certainly much smaller numbers. And we did see responses you can see in these studies. Those are the yellow bars on the waterfall plot, though again, with less evidence. And similarly for the TKIs, a lot of them have started breaking down responses based on kinase domain or non-tyrosine kinase domain, exon 20, non-exon 20. And there have been differential response rates reported with some lower response rates when you get outside of the kinase domain, but still potentially clinically actionable in my book.
All right, so how did AI Jane do with the last one then?
She did okay. I think my sense of this one is I think she, again, maybe confused mutations and overexpression, right? I think when you think about, I should say category of therapy, ADCs versus TKIs, I think for an ADC target, we have pretty neutral data across the board for activating pathogenic mutations. I think for the TKIs, we have more evidence, but again, more mixed responses in and out of the kinase domain. And I think it speaks to the heterogeneity of HER2 and the real importance, if you're finding this on your genomic profiling, to look up the mutation. I search almost all my HER2 mutations in OncoKB to see what we might see in terms of pathogenicity, whether it's a good target. Yeah.
So let's highlight that for a moment, because this is something, once we all leave here and we're seeing patients in clinic and it's busy and you get a HER2 mutation. I know you mentioned it before, but can you highlight when you see a mutation, what are the resources you're going to then identify, is this something that's really actionable?
Yeah, and unless it's, say, a YVMA exon 20 insertion, that's the one that's most common, I'm going to look it up. And, the NCCN lists, there's many different online resources to look at a mutation, whether it might be pathogenic or potentially actionable. I do like, again, I don't work for I don't have anything to do with OncoKB, but I like OncoKB as a resource. It's very easy to enter data, and it'll give you a feed out. And that's what the NCCN includes in their little footnote in the guidelines as a suggested recommendation. And it's, I think, good practice for HER2, because there are non-pathogenic and neutral HER2 mutations that you will find on reports which are not so clinically actionable.
So Anne, Julia just went through a whole bunch of data. Take home, what is your impression on efficacy, toxicity, as far as the use of trastuzumab deruxtecan?
I think, well, just to dial back to the first question, I think that comes up in clinic a lot with the fellows. Is it a mutation? Is it overexpression? is there an amplification, and what's the difference? And I think that's really important to recognize that those are all different, and that it's a dynamic field, and we're still trying to understand what's the most important if one trumps the other. I think TDXD is really an excellent tool for us to use. I think we do need to use it with some understanding of the toxicities, and specifically, I think that the ILD, I mentioned the heart failure too, but we don't know some of that data in terms of what regimen they had beforehand, if it was immunotherapy, if that sort of predisposes them to some issues around ILD. I think we're still learning from it.
Yeah.
Excellent. And one more question submitted: are HER2 overexpression and or HER2 mutations a prognostic marker?
That's a good question. A lot of times we see written that they may be markers of poor prognosis. I think that's older data, and I think that predates the ability to target these with an actionable alteration for our patients. So I suspect that some of that has changed now that it's an actionable target. But it's certainly something I want to know about in my patients, and I'm testing for it. Yeah.
Excellent.
Perfect. All right, so I'm going to take us through, we're going to shift gears, we're going to go through a series of different ADC targets. So we're going to turn to HER3 now as a target. And again, this is now it doesn't have an FDA approval, but certainly I think an emerging agent that I expect we're going to see in the clinic. So we'll talk first through what is the data that we have for this agent. So HERTHENA-Lung-01 is the largest clinical trials that we have with HER3-DXd. This was for patients with previously treated EGFR mutant lung cancer with prior EGFR TKI, prior chemotherapy, looking at outcomes, efficacy, and safety. And you can see here the kind of results off the study showing patients with prior TKI and chemotherapy response rates around 30%, really very similar across all the different subgroup analysis, PFS of 5.5 months here in this study. This is the waterfall plot, just highlighting that, like many of our ADCs, these are meant to be all-comer strategies, so very independent of what the acquired resistance is, EGFR dependent versus independent. That's what those purple and blue boxes there at the bottom really spread across the waterfall plot. Efficacy has also not seemed to be predicted by HER3 expression. That's often a question: is HER3 IHC necessary to select patients, like it may be for other ADCs we're going to talk about tonight? The answer is no, really spread across all different HER3 levels. And the toxicity, I think, is familiar now from what we've seen for ADC toxicity profiles, with I think fairly standard sort of cytotoxic-related side effects like nausea being most common, and cytopenias. And as before, just as we saw for the trastuzumab data, we also see CNS activity with other ADCs here. Again, now highlighting CNS response rates, again, 33%, comparable in small numbers to the systemic response rate. So there is an ongoing phase 3 study, the HERTHENA-Lung-02 trial. This is moving this up a little earlier line of therapy, so patritumab deruxtecan versus chemotherapy, so moving it pre-chemo. And this is ongoing, and I believe there was a press release saying that this had positive PFS data, but I think more to come once this actually reads out and we know more information. All right.
Excellent. So now we'll switch gears and talk about TROP2, the evolving evidence in ADCs and these populations. So first of all, a question for the audience: how did the TROP2 ADCs perform versus docetaxel in randomized trials? If you were just at the debate, you kind of got all this information up front. So options being docetaxel showed superior PFS and OS outcomes versus ADCs. Docetaxel showed superior OS, but ADCs showed better PFS. 3 ADCs showed superior PFS but worse OS, or 4 ADCs showed superior PFS and a trend toward improved OS. 5, I'm not sure. Okay. Good. So the majority, yes, superior PFS, trend toward improved OS. 18% not sure. There we go. So TROPION-Lung01, this was randomized trial, Dato-DXd versus docetaxel. This included squam and non-squam, as well as those with and without actionable genomic alterations. Now, overall, in the squamous on the right, you'll see that it favored docetaxel. In progression-free survival on the left, progression-free survival, non-squamous with and without, favored Dato-DXd, statistically significant, 5.6 versus 3.7 months median PFS, with a hazard ratio of 0.63. In those without actionable genomic alterations, hazard ratio was 0.71. So we know that it was particularly good in those with actionable genomic alterations, but even without, that result still holds up. Dato-DXd for overall survival, again, on the right you see squamous really in favor of docetaxel, but on the left, again in favor of Dato-DXd, 14.6 versus 12.3 months, hazard ratio of 0.84, confidence interval does cross 1. If you look all the way on the bottom there, with actionable genomic alterations present or absent, you see a difference. So present, 15.6 versus 9.8 months, that was only 17% of the population. So it's smaller numbers, so the confidence interval still crosses 1, hazard ratio of 0.65. Without actionable genomic alterations present, 13.6 versus 12.3, confidence interval 0.89, and again crosses 1. EVOKE-01 was SASE versus docetaxel in the second-line setting after prior initial platinum-based therapy and immunotherapy. In this one, the primary endpoint was overall survival. It hazard ratio of 0.84, but confidence interval crossed 1. 11.1 months versus 9.8 months. You see on the right there in the forest plot, for both squamous and non-squamous, not really a difference between the two, both of them leaning in favor of SASE, but again, crossing the confidence interval crossing 1. For progression-free survival, it was closer. So median of 4.1 versus 3.9 months, hazard ratio of 0.92. You see the response rate was actually a bit higher in docetaxel at 18 versus 13.7%. The median duration of response being a little bit longer in the SASE arm. So again, if you can go back to your app, you don't have to scan every time. As long as you open the page again, it should just bring you to the next question. All right, but we're going to continue on while you answer that. So looking at the toxicity profile, so with Dato-DXd, stomatitis was the most common, 47% with any grade. Remember, grade 1 is asymptomatic, but grade 3 is bothersome for sure, 7% of patients. Nausea was also present in 34% of patients. Now, ILD, let me see. So ILD mentioned on the bottom there, 9% of patients with any grade, 4% with grade 3 or more. Docetaxel had the toxicities that we know with all the cytopenias. As far as dose reduction or treatment discontinuation, this was less, grade 3, less with Dato-DXd versus docetaxel, despite being on therapy longer, a median of 4.2 months as compared to 2.8 with docetaxel. With EVOKE-01, with SASE, here is the tornado plot looking at the toxicities of SASE versus docetaxel. You can see really the most common being diarrhea, 42% with any grade, 10% with grade 3 or more. And that's usually for a few days after the dose and something where they get treated with Imodium. Cytopenia is more in docetaxel as we expect. Also, less grade 3 toxicity, less leading to discontinuation or dose reduction. All right. Now, another audience polling question. So this is a new one. Select all that apply. So this is complicated. You have to pick as many as apply. Which of the following are recommended strategies for prophylaxis and management of mucositis stomatitis associated with treatment with Dato-DXd? 1, use of steroid mouthwash 3 to 4 times per day. 2, cryotherapy by holding ice in the mouth throughout infusions. 3, good oral hygiene, brushing after meals and at bedtime, flossing daily, good hydration. 4, consider dose delay and or reduction for all grades. 5, I'm not sure. tougher with the percentages, but because it's all right. But a lot of those. So let's dive into this a little bit more.
It's a good.
I'm going to need AI to help me. So, all right. So, prophylaxis. So, gently brushing after meals and bedtime, using a soft toothbrush, daily flossing, daily use of steroid-containing mouthwash 4 times per day. On the right there, you'll see an important note is that for grade 1, you maintain the dose. Grade 1 is asymptomatic. You see it, but the patient doesn't experience anything. Grade 2, consider a dose delay and or reduction. I'll point out that in the phase 1 dose escalation and then dose expansion, we saw that at 4 milligrams per kilogram, there was pretty good efficacy at that dose. So right now, the dose is 6 mg per kg, a dose reduction. We've seen in prior studies that also held up as far as efficacy, and so you shouldn't be afraid of a dose reduction if it is in fact required. All right, and so with that, now we're going to discuss a bit, but this is now the post-test question. So please do make sure that you now answer that post-test, so we are getting that. But with that, Anne, I've kind of raced through 2 different drugs. What's your take home on SASE and then also Dato-DXd within the non-small cell space?
Yeah, I think the SASE data is a little less impressive. I think that the Dato-DXd, you do see that PFS and a trend towards OS. I wonder if there is a select population that can really benefit from these drugs.
Good point. All right, let's move along to some of that, and then we'll discuss more. So which of the following statements, hopefully you've all done the post-test question already. I'm racing you through. We're really challenging you on these questions versus AI. So which of the following statements accurately characterizes the current evidence on biomarkers for selecting patients with advanced non-small cell lung cancer most likely to respond to the TROP2 targeting ADC Dato-DXd? So specifically for Dato-DXd, what are we looking for? 1, TROP2 expression does not indicate likelihood of response. 2, genomic testing and a normalized membrane ratio may better identify patients likely to respond. 3, genomic testing can identify patients likely to respond. 4, a normalized membrane ratio has shown promising results, but genomic testing does not identify patients likely to respond. 5, I'm not sure. Okay, this is good. So a smattering, and so we have some information to discuss with this. This is good. Okay, so now let's get AI Jane's take on this. So AI Jane, are there any biomarkers that could be used when selecting patients with advanced non-small cell lung cancer most likely to respond to the TROP2 targeting ADC Dato-DXd?
The optimal biomarker for selecting patients with advanced NSCLC most likely to respond to datopotamab deruxtecan is the TROP2 normalized membrane ratio, or NMR, determined through a computational pathology approach called quantitative continuous scoring, QCS. This biomarker measures TROP2 expression on the cell membrane and in the cytoplasm, providing a ratio that predicts treatment response. The TROP2 QCS NMR biomarker represents a novel and effective tool for identifying patients with advanced NSCLC who are most likely to benefit from datopotamab deruxtecan therapy, particularly in non-squamous histology cases without actionable genomic alterations.
Yeah, so
Okay.
Jacob, how did GI Jane do?
Well, I'm impressed that she's saying the drug name right.
Yes.
But I think fairly well. There's more to add to that, I think, and so let's discuss some of that. Now, to start with, the normalized membrane ratio component of this. This was, of course, presented by Dr. Garasino at World Lung last year in the presidential. Now, this is not just looking at TROP2 expression, but TROP2 expression on the membrane surface as compared to intracellular. And ultimately, it's a little confusing because the lower the number, the better. Membrane is the numerator, denominator is membrane plus cytoplasm. The lower the number, or less than a normalized membrane ratio of 0.56 is positive. So 75% of cells having less than 0.56, meaning that when there's more that's intracellular as opposed to within the cytoplasm as compared to the membrane is where you get a positive result. Now, this was a little surprising, I'll admit. I thought that it was going to matter more to see more on the cell surface, thinking that way we're targeting it, but in fact to see more intracellular, I'll speculate, maybe means that there's a higher likelihood of internalization after it does bind on the surface receptor. In either case, from this data, we do see what looks like an effective biomarker. Now, this is taking the TROPION-Lung 01 data, and you'll see on that chart, even if you can't read it, I'll just explain it to you, showing that in those that were QCS negative, when the test biomarker negative, the first of all, the docetaxel arms, both of those overlap each other. So this is not prognostic. If we saw a separation based upon the biomarker, that would just suggest that this is prognostic. Those overlap each other. When we see the normalized membrane ratio as a positive biomarker as compared to negative, that's where you see the clear separation in those curves. And so that's where that one that separates out is the Dato-DXd with a positive biomarker test. So this is very encouraging as far as an initial look based upon progression-free survival. Now, the other thing, though, that AI Jane didn't mention is EGFR positive. We know that from the TROPION-Lung 05 and 01, this is the combined analysis that was presented at ESMO Asia at the end of last year, 2024. You see that the present actionable genomic alteration, a PFS hazard ratio of 0.35. That's really quite good. Now, overall survival, confidence interval crosses 1, but hazard ratio of 0.66. And this is, you see there, multiple different EGFR mutations included. Now, TROPION-Lung 01 and 05 included multiple actionable genomic alterations, and there is, we've described out comparisons of EGFR and ALK and the others, although the others are much lower numbers, and really the EGFR group overwhelmingly looks better even than the ALK group, and so is an area of particular attention and the submission to the FDA. Furthermore, when looking at the efficacy, you see in those who had gotten prior osimertinib therapy on the right part of that chart, the response rate to Dato-DXd being about 45%, and you see the progression-free survival and overall survival curves there on the right. All right, so in going through all the TROP2 data now, again, there is a QR code there. Make sure you do the post-test as well, where you maybe didn't realize that you're the experts that are actually competing against AI Jane. But we know especially after all the sessions in there today, it'll be interesting to see how that plays out. So please do the post-test there. And then as you do that, we'll discuss. So Anne, now with all of the biomarker testing, what are your thoughts around this, and how do you think this will end up altering, or will this be used in active treatment, assuming, of course, the drug's available clinically?
Yeah, I think that the idea of selection, I think we don't really have a great understanding yet of how to, and I'll talk more about some other ADCs, how to select the patients that are going to do the best, if it's really what the best biomarker is. I think the one that you went through in terms of the qualitative staining is really important. I think that's sort of opening the world into a different way of looking at what's happening in a dynamic fashion with these markers, not just necessarily just the presence of something on the surface, but what's happening more dynamically. And yeah, I do think there's going to be a role in a select population for these drugs.
So, submitted questions, what kinds of ocular toxicities? Thank you for asking that. So, ocular toxicity, I think there's still a lot for us to learn about what exactly is going on. I can say clinically, or what patients experience, is more like a dry eye sensation. Lubricating eye drops are generally quite effective. In the studies, patients were required to be seeing an ophthalmologist. I think in practice, most patients, really, there's not a lot for the ophthalmologist to add. But anyone who's developing symptoms, I think it's worth just putting in the referral and making sure they see ophthalmology. There's not a rush to that. I mean, if they have no vision changes and it's just they have like the dry eye sensation, kind of like we're used to with pemetrexed, where you prescribe them your favorite eye drops to use. And usually that's effective when patients do that. But if it takes some time to see ophthalmology, I think it's still worth getting that lined up. So Julia, why does Dato-DXd work in EGFR mutated non-small cell lung cancer?
I wish I had the full answer to that, because then I think we'd be a step forward in how to move forward in selecting agents for these patients. But the truth is, we don't know, could there be some imbalance in TROP2 expression, maybe not as measured by IHC membrane expression, by these more novel quantitative biomarkers looking at changes in internalization. But certainly it's a useful marker, and I think it speaks to I think we expect in the coming months to year, availability of multiple ADCs for EGFR at TKI resistance. And that, again, is I think why we don't know. Is it the same population will respond to all of these, or is it different populations of patients where if we could select properly, we could get a better response across our entire patient panel?
Now, along those lines, that QCS testing, the normalized membrane ratio testing, was developed for non-squamous, non-actionable genomic alteration cohorts. But when we look at overall across the different cohorts, that was positive in a higher proportion of patients with actionable genomic alterations. There's a lot more study that needs to happen on this, but is it in fact also working in that cohort and therefore identifying that there are more patients with tumors that are in fact actionable? So maybe in that population we are seeing something such as higher internalization. I'm speculating on this related to my answer before about noting that we see better responses, particularly in those that have more that's intracellular. All right, with that, I will pass it to Dr. Cheng to discuss other ADCs on the horizon.
Great. Okay, we're going to start out with a question here. Which of the following represent cohorts enrolled to the Luminosity study evaluating telisotuzumab vedotin, Teliso-V, in patients with advanced non-small cell? EGFR mutated with increased MET expression, that's high intermediate. Number 2 is EGFR wild type with increased MET expression, high intermediate. Squamous cell carcinoma, all of the above, or I'm not sure. Please vote. Okay, I'm not sure, 30%. All of the above, 30%. Okay. So let's ask AI Jane. Let's see, let me ask your question. Which patients with which specific genomic alterations were enrolled to the Luminosity study with Teliso-V?
The Luminosity study enrolled patients with non-squamous NSCLC characterized by 2 specific genomic and molecular features. 1. EGFR wild type. 2. c-MET protein overexpression. Enrollment required tumors to exhibit c-MET protein overexpression, determined by immunohistochemistry. This was defined as high c-MET expression, greater than or equal to 50% of tumor cells with 3+ staining. Intermediate c-MET expression, 25% to less than 50% of tumor cells with 3+ staining.
Okay, well, that was GI Jane. If you look at the slide, that's the luminosity study. And in green, you can see that you had non-squamous EGFR wild type, and they were split into two groups, CMET high and CMET intermediate. And then there were also non-squamous EGFR mutant groups, again, CMET high and CMET intermediate. And then there was a squamous cell population as well. So the squamous and the EGFR mutant non-squamous cohorts met stopping criteria, the futility criteria, and so they didn't proceed. And what I'm going to show you in the next slide is the EGFR wild type non-squamous cohort met criteria for expansion in stage 2. And that's shown over here. So the waterfall plot on the right, you can see that in red, the bar is overall response rate in the CMET overexpression total, around 28.6%. And then the CMET high, it was higher at 35%, and CMET intermediate a little bit lower at 23%. So a little bit higher with increased CMET expression, but overall pretty nice 30% overall response rate with DCR rate of 60%. How is it tolerated? Treatment-related adverse events are shown here. The peripheral sensory neuropathy thought to be, that was about 30%, and 7% at grade 3 or above. That's presumably due to the payload. The peripheral edema, around 16% with 2% grade 3 and above. And then otherwise, some of the other things that we've talked about, decreased appetite, LFTs, pneumonitis at 10%, hypoalbuminemia, nausea, and then some vision things. The A's of special interest were, as I said, the peripheral neuropathy, the corneal pathology, and some myelosuppression. And then finally, the adjudicated ILD was at 9%, all grades, 5.2, grade 3 and above.
All right, so AI Jane seemed to answer a portion. I mean, this is making me feel comfortable that we're not losing our jobs in the next year, but kind of missed on part of that. Do you want to go over and kind of grade her?
Yeah, I think she reported out on the cohorts that were positive, but she missed out on the ones that were stopped because of futility. And that's really important because that was, those are patients that were enrolled into the trial, and it's important to know that it didn't work for them.
Yeah, so Julia, why do you think it's not working in that cohort? So EGFR mutant stopped. What do you think's going on there?
Yeah, I think I agree. It was a really important cohort for the study because it helps us understand some things about EGFR biology, which is when you're targeting a heterogeneous actionable resistance mechanism like heterogeneous MET overexpression, you likely need to continue the TKI backbone to retain disease control of the remainder of the other portions of the other clones of the disease. And I think we saw that when you contrast the results of Luminosity study, where response rates to monotherapy in EGFR mutant lung cancer at resistance, so acquired resistance, were low. But if it was given in a different trial combined with osimertinib, the response rates were quite good, I think breaking 50%. Speaking again to the thought that in some settings you do need the TKI backbone or something to control the underlying driver clone. Now that's different from some other ADCs. We saw the Dato-DXd data, the HER3-DXd data, where you didn't need the TKI necessarily for activity, but that wasn't heterogeneous acquired resistance necessarily. And certainly the jury is out. We actually have combination study cohorts that have been ongoing. We're waiting to see response data to see if we get any increase from adding a TKI.
Excellent. Let's go on and we can do some further questions.
Okay. So back to audience polling, our experts here. Is testing of B7H3 important when treating patients with ifinatamab deruxtecan, IDXD? Number one, no. B7H3 expression has not been an indicator of response to the treatment of small cell lung cancer. 2, yes, preliminary results show that B7H3 normalized membrane ratio testing is promising. 3, yes, high expression of B7H3 by IHC. 4, yes, any expression of B7H3 by IHC. And 5 is I'm not sure. Please vote. Okay. It's dynamic, but I think that I'm not sure is the highest over here. X, and then no, B7H3 is not an indicator. All right, so we're going to go to GI Jane and ask her this question. Is testing of B7H3 important when treating with IDXD?
Testing for B7H3 expression is highly relevant when treating with ifinatamab deruxtecan, a B7H3 ADC. Studies have shown that therapies targeting B7H3 are more effective in tumors with high B7H3 expression, making its assessment critical for patient stratification and predicting therapeutic efficacy. Additionally, B7H3 expression correlates with immunosuppressive tumor microenvironments, further supporting its role as a biomarker to guide treatment decisions.
All right, well, that's making me feel even better. So that's really off. So go ahead through the data, but I just want to make sure people aren't taking that as a take-home point.
But she has a great smile. She's
very convincing. Yeah.
Very
Yes,
pleasant
yeah.
when presenting on the dirt.
Okay. So this is IDXD in extensive stage small cell, and you can see the waterfall plots here for 2 doses. On the left is 8 milligrams per kilogram, and on the right is 12 milligrams per kilogram. Very nice waterfall plots. And the overall response rate at the lower dose is 26%, going up to 55% in the higher dose, and really impressive, disease control rates, which is important to our patients as well. The PFS on the left for the 2 doses is 4.2 and 5.5 months, and on the right is overall survival, even though it says PFS, sorry, and it's 9.4 and 11.8 months for the higher dose.
Okay, so do you want to analyze AI Jane's answer on that one?
So she was really pleasant, but she was really wrong. So, I mean, I think this is where you have to be really careful with AI, because sometimes the answers sound really good. I mean, could it be involved in tumor immunosuppressive microenvironments? Yeah, but we just don't know that yet. And I think that that's where I just think these experts in the room, my colleagues, I think it's important to have those experts to really filter the information from AI.
Yeah, so thus far, B7H3 testing is not something that's indicating responses, but maybe the problem's with us. Maybe it's a matter of the assay development. We've already presented that in TROP2, the earlier look at biomarker with TROP2 IHC, we didn't really see anything, but now with that normalized membrane ratio, looks like it might. B7H3 thus far hasn't. Maybe it's a matter of development. AI Jane is living in the future, and so...
maybe she knows something we don't know.
Maybe she does. So, the hope is we will get there. I mean, obviously, we all want that biomarker. We want the story to make sense. We want that logical target that we're hitting. Right now, the technology hasn't identified it. Doesn't mean it can't, but the answer that AI Jane gave is wrong.
And I do think it's interesting because there is some data that shows that, for example, B7H3 is mutually exclusive, the expression in small cell lung cancer with PD-L1 staining. So those patients who are high B7H3 have low PD-L1 and also CTLA4. So we're learning a lot about that, but not yet for prime time.
Okay, can go to the next.
Okay. Okay, so I think this is our last question. Select all that apply. What makes SEZ6 a good target for treatment of small cell lung cancer? SEZ6 is expressed in 50% of small cell lung cancer. SEZ6 expression on normal tissues is limited. SEZ6 targeted treatment, ADCs, has demonstrated efficacy in small cell lung cancer. SEZ6 is a transmembrane protein, making it accessible to circulating drugs. I'm not sure. Please vote. Oh, okay. Lots of votes there, so we'll move forward, and hopefully we'll answer this. Okay, great. SEZ6 is highly expressed in small cell and neuroendocrine neoplasms. It's a transmembrane protein. You can see all the way on the left here is the expression in the neuroendocrine tumors, very limited in normal tissue. Note it is expressed in over 80%, not 50, 80% of small cell tissue. That's a big hint. And then let's just go on to the ABV-706 drug, which targets which is SEZ6 targeting ADC, waterfall plot shown there, an impressive 60%, and many of these patients were third line at study enrollment, so highly pretreated population, and also more than half were platinum resistant, so nice activity there.
So again, go into the app or scan to then do your post-test. We appreciate you for doing those. Now, that waterfall plot is not the look of a small cell waterfall plot. I mean, that's a pretty...
Especially pretreated, right?
Very impressive response rate, 60%, 60.9%. But even beyond that, more with reduction in tumor as well. So overwhelmingly, what was the toxicity of this?
So pretty well tolerated. Again, anemia, some of the myelosuppression, grade 3 was relatively high, but pretty manageable. Again, I think the other thing we think about, especially in our small cell population, is there any activity in the brain? And there were 4 patients out of 7 that had some intracranial activity there. So really exciting.
Yeah, 4 out of 7. 4 out of 7 that were untreated intracranial mets. Question on here now, going back to Teliso-V. Julia, is c-Met testing needed as a biomarker for Teliso-V? And how and when do you test for c-Met overexpression in lung cancer?
Yeah, and this is interesting. This again speaks to the heterogeneity of ADCs. I think we see a flood coming towards us. They're going to be available in practice. And for Teliso-V, you do need c-Met testing. This is for non-squamous lung cancer. And actually, kind of like the HER2 data, there was a dose kind of response effect in that the higher your c-Met expression, the better the activity. So MET 3+ is doing better than MET 2+, for example. We saw that in the response rates. So I'm not sure if this became available, what the exact biomarker that would be tied to it, but it would require, I expect, MET IHC testing. And that's variably available right now in clinical practice, depending on the laboratory you work with, your biomarker profiling, or which assay panel you're using. And I think we're entering a phase of lung cancer where we already do NGS, we do PD-L1 IHC, but I think we're going to need a panel of IHC stains as actionable targets as well as part of our standard testing approach.
All right, one more question we'll squeeze in here, but it's not necessarily a simple one. Anne, where do you potentially see ADCs, B7H3, SEZ6, TROP2, fitting into the small cell treatments landscape? We didn't discuss TROP2. There is some data with TROP2. SASE, there are others. Of course, we're skimming the surface. There are multiple other ADCs in development. Fitting into the small cell lung cancer treatment landscape, how would you sequence them with agents such as tarlatamab and lurbinectedin if all agents were available approved?
Wow, okay. I do think that the ADCs look really promising. I mean, response rates of 60% in pretreated populations makes you think about the toxicity if you move it up earlier in treatment, whether or not there'll be less toxicity. So I think that it's attractive to certainly for relapsed disease. It can be another tool for us. I think that right now we have Lurbi, we have Tarla. If we have ADCs, maybe we can sequence those in a way that makes sense for the patient and what they're able to do. But I also think it's interesting to move it up and see whether or not maybe it can replace etoposide or be incorporated into the first-line induction regimens.
So these kinds of studies are ongoing, a lot more to learn. Please do scan the QR code for the last follow-up poll. Unfortunately, we don't really have time for any further questions, but you have submitted a lot of very good ones, so thank you for that. Do visit peerview.com/lungadc25. Please complete and submit your post-test and evaluation for credit. You can download the slides. There's a lot of information in here. And we've raced through some of them, so you can pull that up and look at it at your leisure, and then watch the replay as well. Thank you so much for joining us, to all of you in the room and to those of you online.